My name is Virat Punswat. My background is a dentist, not a doctor or a nurse. But anyway, I have been working for the what we call is a big health insurance system right now in Thailand for almost 15 years. So I would like to share my experiences towards the current health policy in Thailand to you. I'm glad that participants I think it's in more than 10 countries. That's right. Some from Southeast Asia, from South America, from Africa, and South Asia. Is that right? Maldives. Yep. Okay. So I hope that within these 2 hours, after I give a lecture, we can share experiences among us. All of you you can raise your hand in the Zoom. Is that right? There is a sign that raise your hand, and then some administrator will run following number by number. Yeah. In case you may not be willing to ask questions directly, you can write down. Yeah. Ask some question in the from your computer. Yeah. And then we will raise all questions and I try to answer all of you. Okay. So let's start with, I'm not familiar with the technique. Use this one. Start.ไม่ไปครับI'm sorry ไม่ได้ควบคุมจากตรงนี้ไม่ได้
อาจารย์เปิดมาใช่ไหม Let's make a bit, okay?
ไม่ได้
มองเห็นไหมคะมองค่อนข้างจะไกลค่ะไปแบกให้อาจารย์เป็นสไลด์แรกหน่อย
เดี๋ยวนะปุ่มไหนเป็นปุ่มเลื่อนสไลด์ขวาหรือซ้าย
อาจารย์คลิกค่ะขวาได้เลยค่ะ
ขวานี่คลิกขวาแล้วมีอุปกรณ์อะไรที่มันใช้ได้ควบคุมได้
เนี่ยค่ะอาจารย์ได้
ใช้อันนี้ได้ไหม
อันนี้ก็ได้
ใช้อันนี้ดีกว่าโอเคอันนี้ผมมองไม่
ใช่อาจารย์มันมองไม่เห็นตรงนั้นบังเอิญมันไกลไปหน่อย
ไม่เห็นเลยครับครับโอเค I'm sorry it's too far I couldn't see the pointer yep so today there are 4 agendas I will start with the strategic health plan of Thailand with which which is the 20-year plan. We start around in the year 2017 or 18. Okay. And then the second part will be the healthcare and health insurance system in Thailand. I'm sorry. Go to the second slide, please.
No. มันไม่เวิร์กค่ะเวิร์นเมาส์นี้ทำไมใช้ไม่ได้
Okay. 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 Okay, darling. Okay. น้องพอแล้วครับครับพอแล้วผมมองไม่เห็นแล้วครับ
ใช่ฟังเนื้อหาจังเดี๋ยวรอให้มัน
ไม่เห็นแล้วครับลบเอาออกเลยครับโอเคครับ Then the third part will give you the current situation of the Thai children from 0 to 5 years old, and then the last part, as now we have been facing COVID-19, so I'd like to give you our Thai experience towards the universal health coverage within the COVID-19 context. Yeah, and then I will give you some situation which might be fruitful for all of you to deal with the preschool children or early childhood stage within your country. Yeah. I would like to start with the 20-year strategic plan of Thailand. It's a little bit longer period of time. And I think probably it is the first time in Thailand to initiate or establish such a very long time period of the national plan. Yeah. Within 20 years, we hope that our Thai citizens will be healthy with a longer life expectancy over 80 years. At the same time, we hope that our health personnel should be happy as well to face the serious task to deal with compromised diseases or NCD or cancer, yeah, or even aging population. Yeah, which we need to foster all those persons carefully. At the same time, as you know, Thailand is not a rich country yet, so we need a sustainable health system. How can we afford and then can do our health system within limited budget, limited human resource and limited equipment. Yeah, so this is one big challenge of Thai health personnel altogether, together with our cabinet as well, because they have to set aside all the budget and allocate to us. So we formulate the future scenarios towards all those three goals. I would like to start with the health service system. At the beginning, we think that even though we set aside the referral system quite good and very efficient, we still think that all reference or referral system with efficient services should be combined with shared resources among hospitals, among health centers. We need to to do both distribution, allocation, and some sharing resources in order to be able to provide good coverage of health services to our entire population. We need to reduce service congestion at some certain levels. You know that people tend to go to a bigger hospitals. So we just recently we just have a new act according to the Primary Care Act in order to strengthen the grassroots level at the primary care level. So we hope that within 20 years, we can produce 6,000 family doctors and then could distribute out of them to try to cover our villages, not villages, it's a sub-district level. And we hope that all those family doctors can provide as a gatekeeper of the health system at the sub-district and village level. For all of them, if we could accomplish the objective, we hope that we can improve the service equity for all people. So this is our system design in health services. According to the healthy citizens, we hope that people in our age groups could have a proper development, especially in the early childhood development. We hope that when they need health services, they have the right and have the access to care equitably. So we hope that if they could have services when needed, they could have a better quality of life and eventually have a longer life expectancy. For the country, we need to think very carefully about the budget and how to allocate, how to make use of them with limited resources. So it has to be the affordable health expenditure for all of us in Thailand. And at the same time, as we need to expand the life expectancy, so we need to do some response to health risk in order to lessen down the health risk. So people tend to become more healthy and have a healthy life expectancy. So all in all, without good governance at our levels, since at the national level, at the provincial level, at the district level, down to village level, if there is no good governance, we cannot achieve all of those objectives that I mentioned before. So we set aside some key performance indicator for decreasing premature mortality rate in order to be able to longer the life expectancy for more than 80 years. So one major indicator within the Ministry of Public Health is to decrease drowning in children, because in each year, especially during summertime, children cannot swim and then drown and a lot die. So if we could decrease the drowning number of figures in children, then more or less they can partially make the life expectancy to be better. Yeah. We do not hope just only for the life expectancy for more than 80 years. We think that they should live in a healthy situation as well. So we set aside as well the healthy life expectancy for more than 72 years. It means we don't want them to live longer, but with a lot of problem, a lot of health problem, a lot of health diseases. So in order to be able to cope with this health risk, so we need our people to have a normal BMI, and we need to have the stability of the mental health and emotional health as well. So these are two main KPI of our nation. For the health personnel, we set up 4 strategies to achieve the goal. One is try to produce sufficient and competent health personnel and allocate them, try to cover in every district and sub-district level. Yeah. We also think about concern very much upon the appropriate ratio in different levels. So from time to time, we need to come to take a look seriously about the ratio between the provincial level, regional level, and the sub-district level. And at the same time, we need to have a proper ratio between rural and urban area. Yeah. Unfortunately, nowadays, we cannot have all over the country as a compulsory system to try to cover both private and governmental officers to provide services under the universal health coverage. It's compulsory just on the public side, not private side. So this is a big burden for people in the public side to provide health services for all entire Thai population. Yeah. It's a half and half. Half work for the public hospitals and another half work privately. So if we could increase or try to convince the private sectors to work together with the public sectors more and more, then we think that eventually within the next 20 years, our health personnel should work not so hard and can be healthy and happy. Yeah, have happy workplace and life. So I want to stress again about the governance, to be able to sustain our health system. Because in 3 dimensions that when we think about the health system, first, we think that people should get access to care. That's right. Secondly, how to make it equitable. So the coverage, especially effective coverage, is very important. Yeah, for the good system should perform. And lastly, if we can do it better, access to care, good coverage, with in hands of competent health personnel, then eventually we could provide good quality for our people. Yeah, but all in all, without governance, you cannot do it well. So that's the first part of our lecture. Then I will come into details about the healthcare system and health insurance system nowadays in Thailand. It's a little bit complicated, yeah, but because I know that some countries you don't have the universal health coverage yet. Yeah, I will try to explain slowly. Yeah, I would like to start with the milestone of both the left-hand side is the infrastructure distribution allocation of our our health facilities, health centers, hospitals, yeah. And on the right-hand side is the long milestone regarding the health insurance system and even the national health security system. Yeah. I would like to start since after World War II in 1945. At that time is the new era of Thailand to accept the Western medical services from abroad. There are only few medical doctors at that moment. Mostly they were only in Bangkok. So it's not free of charge, but it's informal extension for the public hospitals. After a while, for about 20 years, we think that according to the National Strategic Plan, we think that if we would like to become a richer country and to have more revenue, something like that, well, we need people to be healthy. Yeah, yeah. If we need people to be healthy for all over the country, then we should try to think about the health sector. Yeah, because if you could provide health services for people being sick, yeah, and they can return or be back to work all over the country, that would be nice. So during the first two-thirds National Health Plan since 1962, we try to build up the hospital at the provincial level to all provinces. And then when we accomplish the goal, then we start to downward to the district level, and then eventually to the health center for the sub-district level. Within only 25 years, we have hospital at all provinces. We have a community hospital at the district level, and we have our sub-districts with health center at our level. Yeah. So all in all, let's say before we achieve the universal health coverage, we give more attention, intention to have a very good health infrastructure all over Thailand. On the right-hand side after a period of time with the informal exemption, in the year around 1975, we tried to establish what we call the prepayment scheme, which if you would like to have, how to say, the health insurance benefit package, you have to pay to the government, and then when you pay, you know that what benefit package you can have, and then if you are sick, you go to the hospital, and then you get the services hospital provide to you. Yeah. But after about 10 to 20 years, we cannot cope with our Thai population with the, how to say, the satisfactory of the figure. We hope that they should have more than 80% of people to get more or less some at least one scheme with the prepayment scheme, but there are still 30% left without any health insurance scheme at all. And all those 30% without any health insurance cover. So when they are sick, sometimes they have to sell their properties to earn money and back to the medical doctors to seek help. Yeah. So this is some big constraint and retard our Thai economy at a bigger scale. So in the year 2000, when we have a big election after a long big queue, is how to say, is Thailand have had a lot of how to say, blood coup. Militaries always come to try to say you are democratic, but you are something like you don't work smart enough. Yeah, then I will come to look after the country. But in the year 2000, when we start to have the big election at that time, there is one party, it's a new party, namely Thai Rak Thai, get a brilliant idea about universal health coverage. And the campaign of that party is, if we win the election, we will give our Thai citizens to have Thai insurance system. Yeah. So after they won the election, and they become a parliament. Yeah, and they try to keep promise and then make it work. So in the year 2001, we start to have universal health coverage scheme, yeah, which cover all the entire population who are not covered by the social insurance scheme or the government official scheme. Yeah. So if you are not covered by social insurance scheme or government officer scheme, you will automatically covered by the universal coverage scheme. So let's say after the year 2001, almost 100% of the Thai population are covered, more or less one scheme of the health insurance system in Thailand. I would like to give you some current picture about our existing health service delivery system. On the left-hand side, the green color, this is the public sector. The blue and violet color is also public sector as well. But outside the Ministry of Public Health, is covered by university hospital or some public hospital under some other ministry. For instance, Ministry of Internal Affairs, Ministry of Defense, But on the right-hand side, the red color is a private sector. And if you look at the figure, the number, you will see that it's almost half and half. So let's say nowadays, there are half of the medical staff working for the private sector, whereas another half work for the public hospitals or public sectors. But when we look upon the universal coverage scheme, according to the National Health Security Act, is compulsory for only public sectors. Let's say only this part. So this part have to provide services for all Thai citizens. So this part, they just provide if you have money. So even though we have a new law, but still that they have a very big burden because they have to cover all Thai citizens at the same time. Well, with only half of all the entire staff in the country. So this is a big problem. So we, at the beginning, only few private hospital or private clinics pay attention to work together with us. So we try to introduce some incentive to convince them. So nowadays, within 20 years, almost 20 years now, there are more and more private hospitals to work together with public hospitals. Also, again, private clinics. And also recently, we have a new policy to convince the drugstores to provide services for our patients. So I hope that within the next 20 years, they can work together, and then there will be more percentages of the people from this side to work together with us to provide services for our Thai population. This is a figure about the dynamics of the health insurance status of Thailand. Nowadays, there are over 65 million population. At first, if you work for the government, you are dependent of the officers. You are spouse, you are children, or you are mother, father of the officers. They are covered by this first level. Yeah. So there are, at the moment, there are over 5 million beneficiaries of this scheme, but it is organized by the Department of the Controller. Is under the Ministry of Finance. Yeah. Okay. So if you are covered by this, then all the rest go to the next step. You are former laborers or former workers or not. If yes, it will be covered by the Social Security scheme. If not, all the rest it will be come to this part we call the safety net for all the entire population, all the rest of the population covered by the universal coverage scheme. Again, when you see different responsible organization, you can see the Social Security Office will take care of all those social workers within 12 million people. And the National Health Security Office, which I'm working for at the moment, will cover about 48 million population. They come from different organizations at each level. So how could we work together? Yeah. Because sometimes, even though you got a benefit from being a government officer, but when you have early retirement, yeah, or your children are over the age of 20, then they will be switched to UCS automatically. How we could link all the data from these three organizations together. Nowadays, we use big data to try to link all data together. Yeah. Otherwise, it's very confusing at the beginning. They are separated from each other. So we work so hard when the children of the government officers are at the age of 20, because they cannot get the, let's say, the benefit package anymore from this scheme. Yeah. So when they go to the hospital, and then when the hospital compute that you are over the age of 20, so you have to pay by yourself. Yeah. So the IT system could help us a lot to try to link our data all together. How user coverage function? I think I would like to give you some overview of what the universal coverage means. If you look at a box, this is a box. There are 3 dimensions. Is that right? This is X, this is Y, this is Z. Yeah. At the first part, the first X, can X. Axis. The X-axis. I forgot English word. We need to think about who is covered. If you could try to cover your system to all population, not leave someone behind, then the x-axis will be covered nearly 100%. And for Thailand, as you know, the previous slide, if you are not government officers, if you are not social worker, if you are not formal workers, then you are covered by the universal coverage scheme. So that means all the entire population is covered right now in Thailand. So the green color here is almost full in this axis. Then go to z-axis. The good universal coverage system in each country should provide as many as possible of all kinds of health services. Again, in Thailand, nowadays, we cover not only the basic or essential health services. We also provide high-cost care. For instance, we cover the hemodialysis. We cover cancer patients. We cover heart surgery, head injury surgery. We also, nowadays, we cover rare diseases, which is very high cost. Yeah. So again, for the z-axis, we almost cover the full of this axis as well. And then the last one, the y-axis. This is very important for the pocket of our population. If you provide services for our population, but still when they need to go to see a doctor and they have to pay more or less partially to the hospital, for instance, 10%, 20%, something like that. So it means patients need to share costs together with the government. So it increased the risk of the finance of the people and their families. Yeah. So it is very risky for people to be bankrupt. Yeah. So the y-axis is to try to reduce cost sharing and fees for patients and their family. Coming back to Thailand. In Thailand, whenever you go to see a doctor, you need to pay what we call payment for 30 baht. Yep. So it means each time you go to see a doctor, you pay $1 US. But it's not compulsory. If you are poor, if you are in a monkhood, if you are elderly people, if you are children, it's free. So it means for this cost sharing, for our Thai system, Thai health insurance system, it's almost free for everyone. with advanced health services cover for the entire population. So that means why Thailand becomes very privileged among, how to say, among the countries, middle income countries, that we could achieve universal coverage within 15 years, and is a good example for other countries that even though you are not rich, you can still have a possibility to make use of the universal coverage concept, to be realistic, in your country. How we do the financing functions prior to the universal coverage formulated and then make it work. The line of command, line of finance, and line of health, human resources came from the same commander, which is the Ministry of Public Health. But after the post-UC, we try to split out what we call the purchaser or the third-party organization out of the health sectors. And HSO, or our organization, is in this part, in the purchaser part. So MOPH still take charge of all health facilities and personnel, but we take care of money, and then we send money directly to the health facilities, to the hospitals, for providing services to our population. And at the same time, purchasers will act as a right protector for our population, and also give useful information regarding health services to our population, to be able to try to communicate with the health facilities, because sometimes, hospitals do not have time enough to communicate with our population of patients. So we try to help health facilities or hospitals, to tackle with all those problems with our populations. This is some explanation about service management using within the referral system here in Thailand. The key point is we must have a contractual facilities as something like a contract unit. Basically at the district level. So all district hospitals will be contractual facilities with us. What we call is a CUP, contracting unit for primary care. And they have to take care of people in the catchment area at the district level. So all the beneficiaries under this CUP, if they have health problem, they start with the health center within that district first. And if they cannot provide proper treatment, or it is too difficult, then they refer to the higher level at the district hospitals. And then if the district hospitals could not provide treatment, it's too complicated, then they refer to the higher level at the provincial hospitals. And eventually, to the regional hospital or the university hospitals as a highest level in the region. Yeah. So all in all, let's say we try to stop people not going bypass to the higher level to have a very serious congestion of patients at the bigger hospital. Yeah. These are the overall benefit package under the UC scheme. We cover health promotion, disease prevention, treatment, and rehabilitation. So at all levels, it's all covered. Yeah. This is I already explained to you. Yeah. And how to do it. If we still use paper, we cannot do it. So we try to build up our own computerized system since the beginning of the establishment in, I think, 17 years ago. Yeah. So hospital claim all the data using the electronic file to our office, and then our office, after we make clear about our documents electronically, and then we reply back and then give money back to them. Yeah. The patients, if they go to see a doctor, yeah, they claim via electronic claim to our office to go to the data server, and then clearing from the prepaid system, and then return back our budget, our money to the hospitals. Yeah. So we don't use paper at all nowadays. Yeah. All is under the IT system. So come to the third part. The third part, I'm going to explain to you about the current situation of our Thai children, 0 to 5 years old. You know that Thailand becomes a very famous about stop HIV from mother to child. We are the first in Asia and the second of the world. We work very hard. Yeah, it's a long marathon. Yeah, to try to stop transmission of HIV and syphilis from mothers to child. Yeah, we have a CL of our drug. Yeah, after 5 years of the UC scheme launch, yeah, we try to reduce the price of the drugs so Thailand can afford, and try to give our patients free of charge. So this is one key critical success, yeah, that I think if you would like to overcome HIV rate in your country, yeah, you need to think about the drug price and the distribution to your patients or your targets. Regarding the child development among different regions of Thailand, even though we said, we accomplished so many indicators successfully, but this slide will disclose and give you something about the inequity among different regions of the country. There are, let's say, this is not the geographical regions, but it is the regional. It's the region of the National Health Security Office. Yeah, there are 12 different regions, and then you can see the figure. The region 10, which is in the northeast of Thailand, the percentages of normal child development is lowest. The highest is in the north. Yeah. This is also in the north of the central region of Thailand. Yeah. So we need to try to overcome this discrepancy of child development in Thailand. Regarding the exclusive breastfeeding, we have national campaigns for many years, but 15 years ago, the percentages is quite low. But after a big campaign for a long time, yeah, after 10 years, it start increasing. Yeah, for almost 4 times. Yeah. For low birth weight, yeah, we still have some problems that we need to do more. Yeah. We have a lot of problem about the teenage pregnancy without ANC, antenatal care. Yeah, they don't even want to go to see a doctor regularly. So that's some probably is that some burden of our Thai citizens in the future. Anyway, for the anemia, it start decreasing, but you see, we start probably is very late. Start the national campaign. Yeah. Anyway, we still have something like the end of the tunnel, the light at the end of the tunnel. Yeah, because it's start to decrease within a short period of time. For the children with short, thin, or fat conditions, it start to decrease a little bit with the fat, yeah, but it's not favorable. But the short is quite good, yeah. The thin is still not so good, yeah. So we still need to fight with the people, with children in both child development and the weight and height of them. This slide will illustrate the success figure of vaccinations in almost all items: diphtheria, measles, tetanus, pertussis, and polio. Yeah, you see that it is almost 100% for all items. So this is very good under the UC scheme, yeah, within 15 years. So I would like to give you the overview of the current health policy for the Thai preschool children, yeah, within the next 2-3 slides. So start with the motherhood. We have a lot of preventive measures, promotion measures, and early screening, since they get pregnant. We have early screening, vaccination, early stimulation for the age at 0 to 2 years old. When they become 3 to 5 years old, we have a big campaign about the child care development. We need to try to convince the local authority to provide social support, more social support, to their children, and have a continuing stimulation for all those in order to be able to have a proper child development. We would like to have more family involvement, have community involvement and support, and close collaboration between community and health personnel. You can see that after COVID, we have a lot of good sign about the community participation, because during the COVID era, they work very hard together, because we set aside some budget from our side to have a matching fund with local authority in every, almost every sub-district level. And then they work together with the village health volunteer very closely to try to help vulnerable groups, to help risk groups, to help people who get patients with COVID-19 in the village. So they work very hard together, and this community participation seems to be very crucial. And I recommend that in your country, you try to focus very much upon this strategy. So this figure will give you the overview of the national campaigns of the Ministry of Public Health for our Thai preschool children. We have a campaign about 4 SMART. Start with the smart pregnancy, smart parents, smart development, and smart kid. So our campaign is called the first 1,000 miracle days of life policy. So we start with a very close collaboration. Start with the Regional Maternal and Child Health Board. They monitor very closely to Provincial Maternal and Child Health Board. And then every province must have a provincial child project manager. And again, at the district level, they have a district child project manager. So when they work closely, they look after pregnant women, they look after early childhood, preschool children, and babies. So they know they have a pink book, and have some history information about what a child got medical treatment from health centers, from the hospitals, and then when the parents carry this book to anywhere, then they can look and see the history, and then could provide proper treatment to that child. No matter you have to move from one to another. For the motherhood, from the National Health Security Office side, we set aside some antenatal and postnatal care and then give incentive to the health facilities if they could provide the full options. Yeah. We also have calculated the budget for the health center to give folic and iodine supplement to pregnant women. We also provide thalassemia screening, including spouse, in order to be able to, if you have a very severe or critical conditions, you can stop pregnant. Yeah. And also nowadays, we start to have a national campaign for the Down syndrome test in risk groups. And also try to campaign the prevention and control of teenage pregnancy. For a baby, after they were born, they will have the thyroid stimulating hormone test in all newborns. We also provide the exclusive breastfeeding, again with some food supplement for all those mothers, yeah, using the local health fund. We have free vaccinations at our stage. You can go anywhere. Yeah. Developmental screening and early stimulation are in the package as well. And also we provide oral examination and oral treatment and oral care. We provide also fluoride gel and varnish application for prevention. Because here in Thailand, nowadays, a lot of children are still have a very poor oral hygiene and have a lot of caries, yeah, a lot of big holes, yeah, which more or less is one critical factor to retard the proper child development. From the age of 3 to 5 years old, we still continue the vaccination for the full dose and also have developmental screening and early stimulation for all of them. And still, regarding the oral health care, we provide prompt treatment. And this year we start with the first fee for service schedule for pit feature sealant and fluoride application for young children, yeah, until the age of 12. We also have a close collaboration between local authorities and health centers to take care of the daycare center and kindergarten, especially the food preparation, yeah, during daytime. And also I think they also give milk every day to children. So those three parts, I talk something about our health policy for young children. Yeah. So the last part, Professor Vantani would like me to give some overview about what the Thai experience is, yeah, regarding the COVID-19. So I just would like to give you some overview. Yeah, I think you know that Thailand was the second country to have COVID patients at the beginning of the outbreak. Yeah, because at that time it started with in China first, and at that time is before the Chinese New Year, and Thailand is a top destination for Chinese tourists to come to have a long holiday here in Thailand. So at that time there was a very big influx from China to Thailand. So we cannot stop COVID at that moment, and Thailand became the second country in the world to have patients with COVID. But how could we cope with the outbreak of COVID? You know, if you look at the figure from the Worldometer, I read yesterday, Thailand becomes the 101 rank in the world. Start from the second country in the world to have patients. Nowadays, we are at the out of the first 100 ranks, yeah, of the world. Yeah, because we have a big collaborations, good and close collaboration between health sectors and other sectors. You see, the pandemic of COVID. I copied this slide. I think about 2 weeks ago. India still is a lifeline, but nowadays they become the third rank of the world. Becomes darker. I think the color is darker. Yeah. Thailand is still yellow. Yeah, yeah. We are not the blue yet. Yeah, because our patients accumulating figure is over 3,000 now. The figure as of the 15th of July, which is last week, is around 3,200. I think yesterday is around 3,250. Yeah. And the death rate is very low. It's only 1.79%. The new, you know, within the last almost, I think, 60 days, there are no more new cases within the country. Yeah. All new cases came from abroad, from other countries. They come to Thailand, and there is a regulation that everyone from abroad need to spend the time within 14 days at the state quarantine. And then they must get swabbed, yeah, right after they landing to Thailand. The key measures that we can cope with the COVID situation come to both parts. The public health part, at that time, we set aside what we call the disaster management center. We have an EOC, and we make decision that we need the active surveillance screening. If there are new cases in the cluster, yeah, they need to go rapidly to go to the village to find risk people, tracing back, and then if they are identified as risk patients or risk people, they need quarantine locally. The health facilities and medical equipment and supplies are distributed, and also the drug. Yeah, at that time we are very serious about the drug, because we don't know which regimen is the best. Yeah, it's still confused. But nowadays, you know, we have I think there are 2-3 regimens. Yeah, and we start with a regimen which is not costly. Yeah, and the how to say that the clinical significance is quite good. But public health sector is not enough. Social part is very important too. At that time, due to the EOC, the provincial governor declared the lockdown of the province. Yeah. So you cannot move freely from your country, from your workplace to your hometown, something like that. And then we have the daily public briefing in order to communicate with people. Yeah, in order to provide some essential message to them. Yeah. We have a big campaign about social distancing, washing hands, and wearing face mask. We also keep protection of the vulnerable groups using some contingency fund, having giving increased allowance to all those groups, yeah, in order to be able to for them to try to have daily life activities. Yeah. Regarding the national health campaign and policy, we declare and announce that no matter you are Thai or not, if you are on the land of Thailand and you got trouble with COVID, you can be treated free of charge. It's free for all people. Yeah. Not only Thai citizens. This is very, very crucial. Yeah, because there are a lot of tourists couldn't go back home and got sick. Yeah. So we treat them all without any payment at all. Regarding the efficiency, we improve management and mobilize resources to fight COVID. We set aside a few hospital using some buildings. We call for collaboration with a hotel to set up what we call the hotel isolation or hospital. Yeah, we can make use of all those buildings. And also, so human resources from the hotel to work something like a first aid for the hospital to take care of risky people. We have a very, very, very good collaboration and participation with the local communities. And in Thailand, we set aside the contingency fund for only $138 million to fight with COVID, both for screening and investigation and also treatment. Why we make use of this lower budget? Because we have our heroes. They are village health volunteers, which is scattered all over the country. Yeah. We have village health workers, village health volunteers in every village, including in a mega city like Bangkok. Yeah. When we start having big trouble with COVID endemic at that time, the local authorities called for meetings, conferences, and then we decided that village health volunteers might be a good strategy to tackle with the active case finding, how to trace risky people who came from abroad and then suddenly disappear from the airport. Yeah, how to tackle with this. So we use the QR code to watch and to make use of. Yeah, and we set aside some short messages promptly to be delivered by village health volunteers to our villagers. They also prepare face masks. Yeah. At that time, there is a big shortage of face masks. So they call for women to make up, how to say, it's a cloth mask, yeah, and providing to almost all households. Another big hero is local authorities. As I mentioned before, we not only provide budget to the hospitals, we set aside some budget to what we call the matching fund with local authorities to provide health promotion and disease prevention activities at the village and community levels, what we call the local health fund. So before, during the COVID era, how could we make use of all this fund to tackle with the problem? They can use the money for providing medical supply to individuals, because the hospital could not provide face masks to local communities, yeah, because they have to use for themselves. So from the people side, yeah, the local authorities must take charge of. So we provide medical supplies, face masks, alcohol gel, yeah, and soap, yeah, for every household. They could set aside some budget for village health volunteers to try to trace back, yeah, and identify risk people and make registry of risk persons and give it to the health authorities. They set aside the local quarantine arrangement, yeah, for people who need quarantine. And they could make use of social media campaign, some educational materials regarding COVID distributed to villagers. So after COVID, we still need something to make more convenience of some chronic patients not need to go to the hospital because it's still risky to go to the hospital. So we provide a new campaign, a new the new strategy to have a drug delivery by village health volunteers. They go to the health center or the hospital, and then the pharmacist will prepare a set of drugs for each chronic patients, and then they deliver by motorbike, to the village directly to all those patients. We also provide mental health counseling for people because they struggle a lot, because most of them nowadays they have no work. We also provide food security for children, especially young children, because we know that during a long close of the school, if they go to school, they have at least a school meal at the daytime. But when they live together with their parents, their family, sometimes parents need to go to work. So they are left at home without food. So they can set aside some money for food security for all those children in the village. And also, we know that during the COVID time, people are very afraid of taking their children to see medical staff for vaccination. So it's time to reinforce vaccination throughout the country. So they can use this fund for reinforcement. This is another very, beautiful picture about the Little Free Pantry, how people help together. It's a social part which is very, beautiful from my point of view. At that time, there are a lot of people try to make shelf and then leave food, drink, or some other essential materials for all who are all vulnerable groups all over the country. You can see this kind of free pantry almost everywhere, every province. I just would like you to get to know that COVID could affect the extreme poverty at the global level very rapidly. You see the figure here. It tends to be decreasing, and then when the COVID started, it comes up and go rapidly within a short period of time, and then it will still exist for many years. And why I mentioned about the poverty with the COVID? Because poverty can affect the health. Children nowadays, 4 million children have no meal at school. At least 13 million children have no vaccine because of the shortage, the cutoff, the logistic or the food chain, something like that, and also the vaccine, logistic of vaccine. So children got trouble and was in a very high priority of the target that we have to try to cope with. So critical concerns during and post-COVID era, I just would like you to try to put more concentrate on. The first is, we know that children, when we talk something about the children and COVID, we always think that, oh, children when they got sick with COVID, it's not very serious, but it's evident nowadays in some countries, in South Asia, in UK, and in USA. What we call is multi-system inflammatory syndrome in children, MISC. And also Kawasaki syndrome becomes more and more evident. So you have to put more concern about this when you have to face the endemic of COVID in your country. If you cannot protect children, you might have been facing with all this syndrome in your children. Secondly, poor access to care among women and children will become more common because we have limited resources. So within the high peak of COVID, all the Ministry of Health or Public Health tends to try to shift or move resources to fight with COVID. So women and children and also some other chronic patients, something like that, they will suffer from the access to care. More malnourished children due to famine and disruption of food supply chain will still exist for many, many months, and a longer period of time. So our children will suffer. And also, more children tend to be exposed to abuse and violence, especially in the family. So these are all critical concerns during and post-COVID, which I would like to stress for the last slide of my presentation. So the new normal of the UHC, we don't only need the technology, but also we need the partnership altogether at all levels. Thank you very much.